Come on.
Good evening, and welcome to the latest installment in the Kansas City Public Library's series of online signature programs. Tonight, we are continuing our series on life in the COVID-19 era with a look at some of the myths and misconceptions surrounding this most recent coronavirus. Our event tonight is being co-presented by our good friends at Truman Medical Center's University Health. We got a lot of ground that we hope to cover, but I'm sure you have questions as well. So if you're watching live, you can ask those in the chat box on the YouTube page, and we'll get to as many of those as we can. Our guests tonight are Dr. Mark Steele and Dr. Paramdeep Baweja. Dr. Steele is the Executive Chief Clinical Officer at Truman Medical Center's University Health. He also serves as Associate Dean in UMKC's Department of Emergency Medicine. He's heavily involved in a nationwide network of top emergency departments that are researching infectious disease threats and testing innovative ways to deal with them. Dr. Baweja has more than 22 years of diverse medical experience, especially in cardiovascular disease. He's a cardiovascular specialist at Truman Medical Center's University Health and an associate professor in UMKC's Department of Internal Medicine. Thank you both for joining us tonight.
Thank you and good evening.
Yep. Thank you.
So before we dive into the myths and misconceptions, I wanted to ask you in particular, Dr. Baweja, about a study that was published Monday that showed that 78 of 100 coronavirus survivors exhibited signs of lasting heart damage. Now that's one study and it's a pretty small sample size, but what, if anything, do you think that we can take from that study?
So the study you mentioned, published just earlier this week from Germany, showed a large number of patients with COVID having involvement of the heart muscle. This was diagnosed by doing MRI scans on these patients. There was another study that actually came out with it that looked at patients who died from COVID and looked at their heart specimens. So collectively, these two studies provided a lot of information about the effects of COVID on the heart. Namely, I think it is a better realization that the heart is more commonly affected in COVID patients than we had previously thought. Some of the ideas that pre-existed these studies was that COVID seemed to cause a lot of inflammation in the heart muscle. This would, for a patient, seem very much like a heart attack. They would feel chest pain, probably have trouble breathing, in addition to the COVID symptoms that they were already having. Some people would have actual heart attacks with a lot of heart muscle damage too. But I think these two studies have shown us that this number is a lot larger than we previously thought, or at least has the potential to be a lot more than we previously thought. The previous reported cases seem to be somewhere between 15 to 25% of the COVID cases, but these studies suggest that that number, especially if using the right diagnostic tools, could be way more. So a few learnings came out of this, in addition to that heart problems are a worrisome part of COVID, is that MRIs could be a very good tool to diagnose the effects of COVID on the heart. There's some anecdotal stuff that has come alongside these studies that the use of the drug dexamethasone, a steroid, seems to help patients with these kind of heart problems do better. And also, it is the other study that I mentioned where we had postmortem patients examined, it showed that even though patients didn't exhibit frank heart symptoms, there was a high concentration of the virus found in the heart tissue. So it appears that just symptoms may not be enough to understand the amount of damage that the heart is undergoing in these patients. Again, this is really early in the realization of the involvement of the heart in COVID patients, but the takeaways are the heart is very commonly affected, what tools we may have at our disposal to look for them, some potential treatment strategies such as dexamethasone that might have some benefit. And it also serves as a reminder to the clinicians that COVID, which we typically expect as respiratory symptoms, cough, shortness of breath, fever, may often more increasingly present with complaints of chest pain, inflammation of the heart failure, gaining fluid, and might mimic more heart attack-like conditions. So a lot of learning messages here from those studies, but again, a lot of work still needs to be done.
So obviously, we're learning new things every day, or at least it seems, about this virus, how it spreads, what it does to patients. There's been this perception since the beginning that it's basically just a bad flu. And maybe that was fed by early talk that people should be on the lookout for flu-like symptoms. I don't know. But is that reasonable? Should we be thinking of COVID-19 as a really bad form of the flu?
Yeah, so I would say no. And the reason being that, as you can tell, there's quite a few more hospitalizations and even deaths that we're seeing than during a typical flu season. And one of the reasons that is that we're dealing with a brand new virus. And so no one has ever developed any immunity to this virus. And so everyone is susceptible. And that's unlike the typical flu, where over the years, all of us have built up some level of immunity. And so the severity is clearly worse and may end up being somewhat like the 1918 pandemic when we had the flu pandemic, and once again everybody was new to that virus, and no one had built up immunity.
What happens when flu season strikes? Is that going to compound things?
It quite possibly will. It just sort of depends, and every flu season is a little bit different. Some are clearly milder and fewer cases, and others that are more severe. And so it's hard to predict what we're going to see. Some start earlier, can start as early as late November, early December, and some don't start until the spring. One thing that'll be interesting to see is that the spread of both viruses is pretty much the same. And so it's by respiratory droplets. And so when we talk or we cough, sneeze, normally we dispel these droplets out into the air, and people can then breathe them in, or they can fall on one's mouth or nose. And so the transmission is similar. And if we're still all wearing masks and social distancing, that may actually help to prevent the spread of the flu when that hits. And so we'll see. Now, obviously, we also have the flu vaccine, which we don't have a vaccine for COVID yet. And every year, is sort of a guesstimate about how good the vaccine is going to be. And until the flu season hits, you don't know how effective it'll be.
Yesterday, I heard someone say something to the effect of doctors are 100% mixed on whether or not this is dangerous. And I thought to myself, maybe closer to 1% might be mixed. I don't know. But let me ask you, is there any significant dissent in the medical community with the core issue here of whether or not this virus is dangerous and deadly?
I think only increasingly are we more and more convinced that this is a much more dangerous virus. Just as we had quoted the studies on the heart that came out earlier this week, there's increasing studies showing how the lungs fail, how increased clotting happens in the body, and how multi-system involvement of organs can happen with this virus at a much more increasing rate than, say, in comparison to the flu. So I think the medical community is pretty convinced that this is a dangerous virus, and we still are looking for answers on how to tackle it.
I think that many of us have encountered those people out there who think that this is nothing to worry about. I'm sure you have as well. Is it made harder when anybody in a position of authority puts themselves out there feeding some of these myths, whether it's doctors with this documentary pandemic or anecdotal evidence of something like first responders not wearing masks when they go into stores? When people in a position of authority are, even when it's a small percentage of them, are contradicting the message, is that hurting us more?
I mean, surely. I think the few things that we have learned about this virus is that there is a very, very high transmission through droplets. And the easiest way to explain that is that when a person coughs, sneezes, or even talks, there is going to be some expelling of droplets from the mouth. With no mask and no distance to separate two people, that is the most common way that this infection travels from one person to the other. Now, as more and more of the community is getting infected, we are seeing this transmission ramp up pretty dramatically. So, one of the easiest and most doable things that we have at our disposal are to use masks, even if they're not medical grade masks. Even cloth masks have shown to have benefit, especially in the community use. And, using a little bit of distance so that droplet infection that we know is a very predominant mode of transmission of this virus is interrupted. So to not recognize what we have already understood about the transmission of this virus is clearly not helping the cause of containing it.
Back in March, when all this was getting started, or at least worldwide it was getting started, and we were still kind of trying to come to grips with how the virus was going to manifest in patients and what symptoms they would show. I remember at one point there was kind of this idea floating around that if you had a runny nose or you were sneezing, it was probably just allergies. There's nothing to worry about. I assume that now we've decided that's not true. What are the symptoms that people should be looking out for, and what symptoms should they maybe not be so worried about?
So the main symptoms are anyone who has a new cough or shortness of air. So obviously there's some people that might have a chronic type cough or have some chronic level of shortness of breath. And so if they're sort of at their baseline, we're not going to be worried about that. But if it's something new or if it's getting worse, obviously that would be a concern. Any fever or chills, fatigue, diffuse muscle aches, headache, any new loss of taste or smell, congestion or runny nose, nausea, vomiting, and diarrhea. So the list of symptoms has actually grown. Now some people obviously do have allergies and they may have sniffles and watery, itchy eyes. But if it's their typical allergy symptoms and it's during the allergy season and there's nothing different about it for them, we're not going to be particularly worried about that, nor should they be. But if it's something new and different and it's one of these symptoms I just mentioned, then they should potentially be concerned about it.
Some of the more rare symptoms, like there's a lot of talk about people losing their taste sensation or smell sensation. There's a variance on how many people actually experience those symptoms. I believe the numbers right now that we understand are somewhere between 10 and 20% of people may lose a sense of taste or smell. So that alone should not be used as a symptom to look for or to confirm whether someone has COVID or not. Like Dr. Steele mentioned, a lot of this is more about understanding a change from baseline condition for people who already may have symptoms or new symptoms of respiratory origin, such as cough, fever, sniffles, even diarrhea. Is almost 30 to 40% of the patients may have diarrhea as a symptom.
Speaking of symptoms and recovery, we have an audience question here. I had the virus tested positive for antibodies. My question is, I have had vertigo since recovering. Is there any evidence of others that have had lasting vertigo while they had COVID-19 or after they recovered?
So vertigo is not a common symptom of COVID-19, but one of the things that people with COVID-19 have experienced is formation of increased clots in the body. That is one of the biggest problems that people with COVID are facing. And some of these clots may break loose, go into the brain circulation, cause a small area of damage in the brain or a small stroke. And that could cause vertigo depending on what part of the brain is affected. So I think that it's not entirely impossible that this symptom comes from sequelae of COVID, but though it's not recognized as a primary symptom that one would expect to look for. Dr. Steele?
Yeah, no, I think that clearly that there are some people who have experienced what we call neurological type symptoms. And so things like confusion, and then I mentioned headache, dizziness. And so I think some of that has been reported, and some of the symptoms can linger on for a period of time after one has been diagnosed with COVID.
I suspect that this isn't going to be the last time that we deal with something like this, and we're going to encounter some of the same things with the science evolving as we learn more and more about how a particular virus spreads and what these symptoms are. What can we learn from this in terms of getting accurate information early and getting people to accept that doctors in science are giving us the best answers based on the information that they have, but that information may change tomorrow.
I think it's true with any new illness that there will be emerging information. I think an understanding on behalf of most people that information could change doesn't mean that the initial information was inaccurate or there was any attempt at misleading. That's one basic sense I think we all need to develop. Doctors are being humbled by this disease and many others all the time as new findings come out or treatments that were initially thought to be effective are not, or new treatments emerge. So this is a learning experience. So trying to keep that open mind that there will be changes, and that doesn't mean that anyone was being misled is one important part of this. And number two, I think public health should involve many different components working in sync. This would include physicians, scientists, politicians, executors, all kind of working together in sync and relying on each other's strengths to formulate policy and disseminate information rather than everybody kind of working independently to say or believe what they, communicate what they believe. I think that's one big lesson that COVID-19 is teaching us.
I think another big lesson is about planning for future pandemics. And I think everyone's aware that we obviously experienced significant shortages in personal protective equipment. And so I think moving into the future, hopefully we develop much more robust stockpiles in terms of trying to source PPE. Very problematic. And it turns out that we don't manufacture much of that here in the US and rely on sources internationally. And I think that's been problematic. In terms of the importance of testing, and we're still experiencing that. I mean, we're doing a lot better with testing, but still there's some limits on some of the resources and testing supplies. And then our whole public health system, which probably hasn't been resourced as well as it should be in terms of being able to do contact tracing and identify cases early on. So the whole planning and preparation, particularly for surge planning, those kind of things.
Speaking of shortages, I was at the store last week, and for the first time probably since the middle of March, I saw hand sanitizer on the shelf. There's that big rush initially at the outset, and then a lot of that supply was understandably redirected to healthcare, to hospitals and to doctors' offices. Is hand washing a better option for keeping people safe, or is there a place for both?
I think there's a place for both, and I'm not sure. I've not seen anything that one is more effective than the other. Hand washing is very effective, but you should do it for at least about 20 seconds. Or if you're going to use hand sanitizer, you want to use a hand sanitizer that has at least 60% alcohol content.
So in those early weeks, there was talk of hydroxychloroquine as a drug with potential to treat COVID. Then there were some studies that showed that it probably didn't work and might actually do more harm than good. What's the current prevailing opinion on that drug? Is it still being studied? Is it worth being studied?
So the current opinion from a standpoint of use of this drug is there is, at least on the recent studies that have been able to establish no effective use of chloroquine in COVID-19. But it's the harm usually here has been because it is, any drug will come with side effects and has some toxicity potential. And if used inappropriately will cause problems. So chloroquine, though, might be a good drug for many other conditions, many other medical conditions that it is used routinely for, when being used unnecessarily for COVID or in incorrect doses was causing harm. So I don't want to create a fear for people who are on hydroxychloroquine for other medical conditions. That's where the benefit has been proven. But the use in COVID-19 was kind of indiscriminate at some point also, and that might have raised some fear in people's minds. But currently, not a very good evidence that it's helpful.
Are there any drugs currently that are recommended for treating the virus, or are we just focused on drugs maybe that can treat the symptoms for now?
So, I'd like to divide that question into two parts. Part number one would be, Is there any drug that can be used in a prophylactic manner or in early outpatient minor symptom patients as chloroquine was being touted to be used in? I think the answer to that is that there is not a clear effective drug right now for those people. On the other hand, for people with more severe disease who are admitted to the hospital, who are in need of oxygen or are even on a ventilator, there have been some drugs that have shown promise. One of the drugs I mentioned earlier, dexamethasone, has been showing promise in patients who are very ill, especially those who are needing high flow oxygen or are on ventilators. Antiviral drug called remdesivir has been shown to decrease mortality and recovery in patients, again, who are more ill from COVID-19. There are some other candidates on the horizon. There's a cytokine or a chemical in the body called interleukin-6. Some inhibitors to that are on the horizon as being studied, as are some other potentials. But the two that are in use currently in our medical setting are dexamethasone and remdesivir.
Just to add a little bit, the remdesivir is actually been shown to reduce the length of hospitalization, at least in one study, and probably giving it a little earlier on in somebody's course is better and is probably more effective in that way. And it helps to prevent replication of the virus. And the other thing that's not a drug, but obviously convalescent serum. So that's serum that's taken from patients who have had COVID already and have built up antibodies. And so that's something that we're fairly routinely giving to people. And there's some studies underway. We don't know exactly how effective this is going to be yet, but we're certainly it's something that we are utilizing.
Another audience question comes in. This one kind of references something that we talked about a few minutes ago, but with well-produced videos like Plandemic and the more recent Frontline American Doctors, what's the best thing that people can do to discern if what they're watching is real or fake?
I think there's a big surge of social media in the last decade, and especially now in a pandemic. There is so much information that floats around on YouTube, Facebook, Instagram. I would strongly encourage people to not use that as a source for verified information, because that's really not what it is. I think more trustworthy sources are public health resources that the medical community and the government both offer. Large dailies and periodicals also have some answerability and tend to be more scientific in their reporting. So I would use those as more reliable sources than social media. Not trying to dish social media as a means of spreading information, but currently, because of how much clamor there is on social media around COVID-19, it is not possible for these platforms to sort through real versus fake news, and hence it confuses people as audience.
So I want to talk a little bit about masks here. And I feel like I should point out our doctors are both at work. So they're wearing masks. I am safely in my home library. So that is the reason I am not. It seems like this is another case where maybe we were hurt by early reports that people didn't need to wear masks. And now, of course, it seems clear that masks are one of the most effective tools that we have for slowing the spread of COVID-19. Can you talk about how the medical opinion shifted regarding masks? And do you think that getting on board with that sooner would have helped us?
So I would just point out that as I mentioned earlier, that this was a brand new virus, so-called novel virus. And so I think there's obviously a learning curve that goes along with that. And so you obviously learn more as time goes on. And we certainly have learned a lot more about this virus. I think also early on, there may have been some concern about what I mentioned earlier about the amount of personal protective equipment we actually had available, and really wanting to keep that to protect it for the healthcare workers and so forth. Obviously cloth mask potentially would have been an option. Then I think they also felt pretty strongly that social distancing alone would be effective, which is technically true. But I think practically that's pretty difficult for everyone to be socially distanced all the time. And so I think it just sort of changed over time, but there's no question that masks are effective.
So is there any discernible difference when you mentioned that the cloth masks would have been an option from the beginning? Is there, in terms of safety that they provide, or cloth masks and medical paper masks the same?
Well, there's different levels of even the medical masks that we have. And so the highest level is the N95. And so that filters out the most, down to a very extremely small size, viruses and bacteria. And then the masks that go down to a lower level that we even have here in the hospital that are probably somewhat comparable to using a cloth mask, maybe slightly better. But even with a cloth mask, the real beauty of this is because of the respiratory droplets and the way the virus is transmitted, it's been shown that these cloth masks capture the vast majority of the droplets that are coming out of one's mouth or nose. And so, and then also provide probably some protection, even if the other person is not wearing a mask, just from the other side. But if both parties are wearing a mask, really pretty darn effective. Obviously, if we had unlimited N95s and everyone could wear N95s, that would be even more so. But that doesn't preclude wearing a cloth mask, because it still is quite effective.
And, I wanted to add one thing. People out there may be able to see masks that have little round valves on them. These valves allow a person to breathe out without using the masks as such. So their breath is exhaled out through that valve. When they inhale in, it is through the protective layer of the masks. I think what I want to pass along is that the wearing of masks has a two-sided effect. Number one is if you are a potential infected person, as you cough or talk, you are not expelling the droplets. And number two, if you're facing an infected person, you're not inhaling those droplets. So those valves make that mask a very one-sided affair, where only one side of protection is present. That is, you don't inhale anything, but you can eject anything out through that valve. So I wanted to point out that if you you want to avoid those masks with the valves on them.
I was going to ask about those. The CDC, I think it's the CDC, has issued findings that people should avoid those because they don't offer that level of protection. And I've seen some people have kind of seized on that report and try to use that to justify saying, see, masks don't work, I told you. But that just applies to that one type of mask, correct?
Yes.
So staying on the topic of masks, some people point to things like CO2, intoxication, oxygen deficiency as reasons why we shouldn't be wearing masks. Are those legitimate concerns, or is this just a case of people who don't want to wear them reaching for any reason they can not to?
Actually, there have studies being done on that now to show, we measured oxygen saturation with wearing no mask, whereas wearing one mask or even two layers or three layers, and N95 and a level 3 and multiple layers of mask, and there was no decrease in oxygen saturation. Blood samples checked didn't have any increase in carbon dioxide levels. So this is really not scientific. Wearing a mask is not harmful for you.
I might put you on the spot here, and if you don't know the answer to this off the top of your head, that's fine. But I'm curious, in a hospital setting, how many hours a day does a typical doctor or a nurse wear a mask?
Well, I am an interventional cardiologist, which means I work in a procedure area all the time, which is a relatively sterile environment. Dr. Steele works in the ER, and I'm sure he may have similar requirements there too. But even before COVID, we wore masks from anywhere from 7 to 10 hours a day, and it wasn't a problem back then. And now with COVID around, maybe that use has increased because now we're even wearing them outside the procedure areas. yeah, I don't think the length of duration of wearing your mask is out here. Dr. Steele, any thoughts?
Yeah, no, I mean, obviously, and even pre-COVID, those who work in the operating room always were wearing masks, and so they could be wearing the mask for many hours in a day, and especially if they have emergency cases that go into the evening and night. The other thing.
Go
The
ahead.
other thing I wanted to say about masks, just and I always like to highlight this, and this actually just got published in a CDC publication, the story of the hairstylist in Springfield, Missouri. And so this was at a Great Clips store, and when they reopened, they required the stylist to wear face coverings, and the clients had to wear face coverings. And it turned out that two of the stylists ended up contracting COVID, and during that period when they were potentially infectious, they had been involved with 139 clients. And obviously, when you're doing somebody's hair, that's pretty close contact for an extended period of time. And not one of those 139 clients got infected with COVID. And so I feel certain that that would have been a different story had they not been required to wear face coverings.
That's a good segue to my next question. Kansas City's mask order went into effect 1 month ago today, actually, and most of the surrounding counties took action shortly thereafter. The cases in the metro area have continued to trend upward for the most part. Have we just not given it enough time, or is there something else at play here?
I think it does take some time when you do something like that. Obviously, it also depends on the compliance level. I feel like when I'm out and about now that there are a whole lot more people wearing masks than there were, it feels like 2 or 3 weeks ago. But you have to first decrease the transmission of the virus, and then hopefully the positivity rate will start to drop as well as the hospitalization rate. And so we clearly have seen a recent increase in hospitalizations during the month of July. The recent data for the last week or so here in the Kansas City, Missouri area, at least, it's sort of plateaued a little bit. And so hopefully we'll see some downturn, but it's hard to know.
Are we to the point yet where we need to think about wearing masks outdoors as well as indoors?
I think it depends on the kind of outdoor activity we're talking about. If we anticipate coming into reasonable proximity to a lot of people, then yes, it makes sense to wear it outdoors as well. On the other hand, if you're going hiking in the woods and don't expect to come across anybody, and you weren't wearing a mask for some period of that time, I would think that's reasonably safe. But I have tended to encourage everybody I know that no matter where you're going, have a mask with you, so that if you start to come around more people than you anticipated or in closer proximity than you had thought you would, getting that mask out and putting it on takes only a few seconds.
I might just add that we know that the risk of transmission is definitely greater in an indoor environment than it is in an outdoor environment. And obviously in an outdoor environment, it's also probably easier overall to actually practice good social distancing. So I think it's a little bit different than it's clearly probably safer and less risky outdoors than it is indoors. But obviously if you have large groups that are congregating outdoors, or you can't be clearly socially distanced, then you should be wearing a mask.
We have another audience question on the topic of masks. A public figure who was recently diagnosed with COVID-19 claimed that he feels wearing a mask trapped the virus close to his face. Is that even possible?
No, the chances are that the virus came to him or her in a period when there was no mask on, by likely that person and the transmitter. And then thereafter, once you're infected, wearing a mask has no bearing on any increased illness or any increased duration of illness.
Social distancing is the other big tool that we have to slow the spread, but I've heard a lot of people have said limited exposure might be okay. Obviously, the longer you're around someone who has the virus, the more likely you are to contract it. But is there any amount of close contact that would be considered safe?
I don't think that, I mean, ideally there would be no close contact, but clearly, as you said, that the longer that you are in close contact, the greater the risk of contracting the virus. And so generally speaking, if you're in close contact for 15 minutes or more, that's much greater risk than less than 15 minutes, but that doesn't mean there's no risk with less than 15 minutes. It's lower, but not necessarily none.
So wear your mask when you're indoors, and don't panic too much if you come within 6 feet of people while you're walking down the aisle in the grocery store.
Well, once again, I mean, that's an indoor environment. I think that if you're outside and you're on a trail and you're walking and you're just walking past somebody very quickly, and the airflow and so forth is different outside. Indoors is a little bit trickier because you don't know how the air is being circulated and recirculated. And so I personally, if I'm in a grocery store, I would be wearing my mask the entire time.
So to sidebar a little bit, since you were talking about the circulation, for a time there, it seemed like every other week we were hearing about meat packing factories that were being shut down. Was that related to I've been in meat packing plants before in the past, and they're cold and air conditioner running, a lot of air flowing around. Do you think that was the reason why it was hitting them so hard?
I think more than the cold, again, it's a lot of people working in proximity, especially when you have processing that occurs in a kind of a belt fashion, which is very common in meat plants. There's a lot of people working in proximity, which again increases the chances of spread. And also, there were concerns of how long the virus could live on surfaces that was being questioned. I think even to date, we don't have a very good understanding of how long the virus can remain infective on a surface. The virus has been isolated from surfaces many hours after exposure, even up to 10 to 12 hours after exposure of a surface to the virus, that they have been able to re-isolate the virus from that surface and culture it. But again, I think the clinical or the scientific lab act of growing the virus from a surface is a little different than its actual infectivity. And the notion of how infective a virus would be sitting on a table surface or on a food material surface is not clearly understood at this point. So I think precaution is probably better right now until we have a more clear understanding.
Or a library book.
Yeah, library book, sure. Yes, of course.
Just in terms of the meatpacking thing, it doesn't always necessarily mean that they contracted the virus at the work site. So you have to remember that sometimes, and as I understand it, that a lot of the workers may travel to work in buses and maybe in close proximity there, and even live together. Their living conditions and how closely they're living together can also have an impact.
We have another audience question here about treatment. And have blood thinners been used as a treatment option, and have they been effective?
So yes, blood thinners have been extensively used. As we had talked a little bit earlier, one of the problems that COVID-19 has come with is an ability to increase the clotting in the bloodstream. So people tend to develop more blood clots. And these blood clots can have very serious sequelae, depending on where the clots form in the lungs. That can cause trouble with breathing. If they happen in the brain, they can cause strokes. If they happen in the heart, they can cause heart attacks. They can even happen in other organ systems of the body. So blood clots are clearly bad. We understand that. And with an increased propensity for clotting with COVID-19, there has been a pretty increased use of blood thinners at various levels. So depending on how sick the person is, different magnitude or different intensity of blood thinning is recommended and has clearly shown to be beneficial in preventing clots and preventing worse things that come with these clots.
There are a lot of parents out there this summer that are struggling with decisions regarding their children, whether to send them back to school or what to do with them over the summer. What would you recommend for parents who are trying to balance safety with their desire to have their children lead something resembling a normal life?
So I've heard this question from a lot of my friends and in the community recently. I think the answer is not easy. There's a lot of pros and cons both sides. Of course, not exposing yourself to more people or to be in more proximity to more people is going to prevent the spread of COVID. But on the other hand, parents worry about their social skills of their kids, their experience in more social environments, and then certain educational courses requiring more hands-on approach. I think if we understand the basic precautions that need to happen, educate our kids as best as we can, have a unified voice in explaining to the people what actually helps, and then designing our programs, education programs, in a way to facilitate those recommendations. Those could be some ways of safely reintegrating students into the learning environment. Again, the unified message, I think, is key. And then as educators, even here in the hospital at Truman Medical Centers, we are a university hospital. We have a lot of learners come through. And, we have adopted to the differences in this COVID time where fewer people, dispersed more, not having crowding in one space, taking learning in a hybrid model where a lot of it can happen online and only the necessary hands-on things bring people in a co-located environment. These are some of the methods that we are using here at University of Missouri and Truman. But this is the kind of model that every learning environment would have to learn to adopt. Dr. Steele, any thoughts?
Yeah, no, I concur that it really is a tough decision, and obviously even more so for people who potentially have more vulnerable family members who are living at home that might have underlying medical illnesses or have older grandparents who might be living there who might be at more risk. And so every time you're sending people out into the community or to school or whatnot, obviously we're going to do the best we can, and hopefully people wear masks and social distance. But there's always that sort of lingering concern about potentially bringing it home.
So what about specifically summer activities? Is it safe for my son to have a friend over? Obviously football is probably a bad idea because it's a contact sport, but a sport like baseball, is that a little bit safer? Is there anything the kids can do to get kind of that social interaction and exercise?
Sure. I mean, I think that the different activities, that some probably are going to be lower risk than others, as you just alluded to. And so, I mean, things like tennis, obviously that would be relatively safe because you're pretty far apart, hitting the ball back and forth. Golf to a certain extent outside, you can probably maintain some distance, those kind of things. Obviously cross-country running or that kind of thing, as long as you're not congregating in groups, a little bit less risk than where you've got really close contact like football and some of the other sports.
So
sorry.
Go right ahead.
One of the questions that I got asked a lot around with my friends in the community was, what about community pools, swimming pools, especially being so hot over the last couple of weeks? The kids want to get out in the pools. So at least as of now, there is no clear evidence that coronavirus will spread through the water in a pool. Firstly, that has not been documented to be a good method of spread for the virus to begin with. And two, pools usually have a lot of chemicals in the water that are used to prevent the spread of infections and viruses and bacteria, which are to some extent going to be effective for the coronavirus as well. But again, the key thing of transmission at pool environments is going to be the density of people and the basic precautions that they will use when outside the water and in the water. So I think those basic rules of distancing, keeping away, masking when possible, washing hands as frequently as possible, especially after contact of any public space, are going to be the more important determinants of keeping these areas safe.
So I've seen a few people have questioned whether there are additional threats outside that don't necessarily exist indoors. One of them is this idea that the virus might be spread by insects like mosquitoes or even flies. Has that been essentially ruled out at this point?
There's no evidence currently whatsoever that there's any spread via insects or ticks or mosquitoes.
Also had somebody ask about pets. Are pets susceptible and can it spread?
To the best of our knowledge, I mean, there's been no cases of transmission from pets to humans. People may have heard that the coronavirus has been diagnosed in a few dogs, cats, elsewhere in the world, but it's felt, at least so far, that that's not likely to be transmitted to humans. And dogs actually can have other coronavirus type infections, so you have to be a little careful about if they're looking for that, what type of coronavirus is, because there's multiple coronaviruses.
And just to reiterate what we've mentioned a couple of times previously, we're learning new things every day. All of this is information based on the information we have at this moment, and could change in the future, right? We already talked about swimming pools, specifically with going back to school. Increasingly, there seems to be kind of a justification that by saying that kids are less likely to get it and less likely to transmit it and have milder symptoms if they do. Can we be certain about that, or does it maybe just look that way because schools have been closed and activities have been canceled?
I don't think that it's absolutely clear yet that kids are less susceptible. There's some suggestion that kids, particularly kids under the age of 10, may be less likely to transmit the virus, but to what degree, we can't know that for certainty, I don't think, at this point in time. It's certainly clear that kids are less likely to get severely sick and ill.
And again, what Dr. Steele said is it's less likely. There are cases and evidence of very sick infants and younger children too with COVID-19. There is also some, fewer, but some reports of transmission from mother to child, either in utero or immediately around birth or after birth too. So it's not that kids are completely immune. That's the one thing we need to remember. And then the bigger determinant here is going to be the kids bringing the virus home and spreading it elsewhere, especially, as Dr. Steele had mentioned earlier, if you have a vulnerable population at home, older parents, grandparents, or somebody with immune deficiency problems, somebody with diabetes, somebody with existing heart issues. These are all people who are increasingly susceptible to getting sicker with COVID. So bringing the bug home can cause more problems than just the thought of what happens at school.
A couple of audience questions related to treatment. There's been kind of a growth, as you would expect in a case like this, of people promoting natural remedies or natural ways to avoid it. Vitamin C is one that people come back to a lot. Any evidence that any of that stuff might help?
Nutritional deficiencies will predispose to various infections, including viral infections, but that is a more general statement than specific for COVID-19. So to have good nutritious food, good nutritious intake, not have any vitamin deficiencies is going to be beneficial to everyone to fight and avoid infections. But no such natural medicine has proven to be clearly effective to fight COVID-19 as of yet.
And then I'm going to mispronounce this, but hopefully I'll get close enough that you all will know what I'm talking about. How widely available is Remdesivir? If I wind up in a local hospital with COVID, what are the odds that it'll be available to me?
So Dr. Steele had mentioned earlier, Remdesivir is most effective when used early on at the presentation in patients who are at least a little ill enough to be admitted to the hospital, potentially to be on oxygen. That's where the highest benefit is. What I mean to say is it's not for everybody. It's not for the very sick on ventilator for already for weeks. It's also not for the mildly ill who may go home, but for that middle population where the oxygen saturations are dropping, there's need for oxygen, or are getting on a ventilator and are within the first 1 to 2 days of being on the ventilator. As to supplies, I think Dr. Steele may have a more informed answer.
Yeah, I think to my knowledge here locally that the patients that remdesivir would be indicated for we've been able to get it for them. Although I've heard some suggestion that may become a little bit more difficult. And so I don't know, a lot of times there aren't endless supplies, and it all depends on how quickly the manufacturers can roll out more of the medication.
So everything we've discussed so far are things that I think that we can at least understand why people might be inclined to believe something. But I'm sure you've seen or heard some things that seem to be a little more out there, and just cover a few of those, ranging from things that are just out of left field, to some that are maybe so far out of left field that if this was Kauffman Stadium, they'd be setting out in the middle of I-70. But we'll go through these a little bit quicker. Do 5G networks play any role in the spread of COVID-19?
No.
Does drinking alcohol offer any protection against COVID-19, or on the flip side, can it make you any more susceptible?
Well, if you're going to have bar parties, then it probably is bad, because the proximity part is going to come into play. But otherwise, alcohol in itself, no.
I might say, though, that somebody who drinks very, very heavily and ends up, and maybe somebody with cirrhosis or some underlying medical conditions, that certainly potentially could impact the severity of the disease that one might get from COVID.
Any truth to the idea that as a self-diagnosis, if you can hold your breath for 10 seconds or more without discomfort, you don't have COVID-19?
That's absolutely not correct, because we know, and the statistics would say that potentially up to 35% of people with COVID never have any symptoms at all. And so that right there should tell you that test alone will tell you that you don't have COVID.
And not a lot of presenting symptoms will be respiratory. A lot of people have presented with diarrhea as their first symptom. We were talking earlier about heart problems, and that could be the manifesting symptoms too. So it doesn't have to be respiratory symptoms that bring you in.
Okay. We touched on this one a little bit earlier, but are doctors and scientists deliberately hiding anything from us regarding this virus?
I would say absolutely not. And in fact, the medical community and the doing research and so forth are generally very transparent and very quick to publish their findings and let people know what the latest science is.
Physicians tend to be also educators. I think, again, one of the misconceptions that could arise could be that the news changes or the concepts or the facts change. And that is the reality of this disease, is that we are discovering every day. But that's not because people are trying to be misinformed. It's that new things are happening. And as new things happen, new information will come that might contradict prior information.
So this one might be a little more nuanced than that. But how accurate is the reporting? There was some discrepancies maybe between states early on in terms of what they were calling a COVID-19 death and what they were not. Do you feel as though that's fairly uniform now and the numbers we're seeing are accurate numbers?
I think the medical community has been pretty consistent in reporting COVID-19. The tests available to us have evolved, surely, and as have the testing means, which means that we may be able to diagnose faster or quicker or in more numbers than we could previously. And that would alter reporting to some extent. But other than that, the test is pretty much what it is. It's not an ambiguous test. It's either a positive or a negative test. There are false negatives and false positives, and that is built into any test that exists. And that part of a test can't be overcome. But other than that, there's pretty discrete information, so there's not much room for ambiguity.
There was a report out of Florida earlier this week that at some of the drive-through testing sites or walk-up testing sites, people would not be able to wait any longer, and they would leave, and maybe the results would get mixed up because then the numbers of the people online are off. Do you see that as something that to worry about with so many people trying to get tested anywhere in any way they can? Or for the most part, are you getting the correct result when you're called?
I can speak for my own experience. I went to public testing at Johnson County a testing campaign, and they were very organized, and they didn't attach your information to the test until they actually were just about ready to collect. So I cannot see a room for that kind of error where mix-up happened because somebody walked away from the line. They were pretty thorough about it, and I didn't see that could have happened. And I can't speak for any other place, but at least in the hospitals and in the community where testing is happening, done by counties and cities and states, they're very organized about it.
What are I'll ask you both this. Is there any myth or misconception that you've heard or a question that you've heard about COVID-19 that stands out to you as being that caught you off guard?
What was the last part of your question?
Is there a question or a myth that you've heard, somebody that thought something about COVID-19 that caught you off guard that you I know I stole the best one with the 5G, but is there anything else that you've heard that kind of left you shaking your head?
I can't say that I've heard anything way out there, but I mean, certainly there, some people have had questions about, can you get it from eating food or from drinking water? And certainly there's no evidence that that's possible that we have currently.
All right. I will close with this then. I wonder, could both of you just kind of give a couple of minutes of advice for the people of Kansas City as we try to navigate this pandemic and cling to some sort of a normalcy? What would be your message to people watching?
I would say that our best defense in this is going to be a collective defense. Two people fighting and two not fighting is going to make us lose the battle. If we come at this together, if everybody understands their responsibility, that wearing a mask is going to protect yourself and others around you, and if everybody participates in social distancing and good, clean hygiene, washing your hands, keeping your home surfaces and your work surfaces as clean as possible, and being attentive to new symptoms and reporting them immediately so that appropriate actions of isolation and precautions can be taken, I think that is going to be our best defense against this virus. And we have to have a collective responsibility, whether we do it for our elderly family members, whether we do it for our family members who are otherwise sick from other medical problems, whether we do it for the pregnant people at home, or whether we do it for kids. But the answer is going to be that it has to be each person's responsibility to protect not only themselves, but the people around them. And if we are not able to come together to take care of this, we're going to fail together.
Dr. Steele, anything to add to that?
Not a lot. That was well said. But I would just reiterate that currently really our two main weapons that we have to prevent transmission of the virus are wearing the mask or social distancing, or both. And so just those things are very, very important. And obviously I think no one would like to have us have to shut down society again and close bars and restaurants like they're having to do in some parts of the country. And so I think this is the way that we help to prevent that, which no one really wants to go there. And clearly that was effective, because when the shutdown occurred, the number of cases dramatically dropped. And it was only after we reopened when we started to see a rise in the number of cases that we've been having.
Dr. Baweja, Dr. Steele, thank you both very much for joining us tonight. This has been very informative, and I appreciate you taking a little time out of your evening to spend with us.
Thank you. Good night.
Thank you.
Good night, everybody.